Hello everyone. Today we are going to discuss a very important topic, tetralogy of Fallot. Tetralogy of Fallot. Before discussing the main topic, I want to show you one picture. He is doctor, French physician, Doctor Etienne Louis Arthur Fallot. Now, in 1600s, what used to happen was there used to be children who would cry and turn blue. No one knew what was the cause for them to of turning blue, so they were just being called as blue baby syndrome. In 1888, uh, Sir Etienne Louis Arthur Fellot first described the four components which were common among all those children who would turn blue. So for that, the we call that tetralogy of Fellot, right? So as tetralogy means tetrad, there are four components of tetralogy of Fellot, and you should remember all the components of Fellot and what does that mean, right? So the first component, first and the most important component is right ventricle outflow tract obstruction. Second is the large non-restrictive VST. Third one is the aorta overriding the VST. And the fourth one is right ventricular hypertrophy. So let's understand each component in detail. So this is the schematic diagram for the heart. This is right atrium. This is left atrium. This is right ventricle, and this is left ventricle. This is pulmonary artery, right? And this is aorta. Now you can see this is the VSD. The gap that you can see here is VSD gap, right? So the most important component of this is the right ventricle outflow tract obstruction. So let's understand what is right ventricle outflow tract obstruction. My drawing is not that good, so bear with me. This is your right ventricle. This is your right atrium, right? And these are your pulmonary valves and main pulmonary trunk. So this is your right ventricle, right? And this is the outflow tract. This whole is the outflow tract. We call this right ventricular outflow tract obstruction, not the pulmonary stenosis or anything else. Why? Because the obstruction can occur at three levels, three main levels, right? The first one is this one. This is the infundibular level. This is the infundibular stenosis. And this is the most common form of obstruction seen in TOF. Right? This occurs due to the hypertrophy of the muscle and the anterior displacement of the infundibular septum. Second important site of obstruction can be valvular stenosis, pulmonary valvular stenosis. And the third one can be supravalvular stenosis. In that infundibular stenosis or subvalvular stenosis, infundibular stenosis can also be called as subvalvular stenosis. This is the most common site of obstruction to the right ventricular outflow tract, the tract formed by formed at or near the exit to the right ventricle towards the pulmonary artery. And the most common site of obstruction which you can see is the infundibular or subvalvular stenosis. Now the site of obstruction is important because it would have implication in the treatment of the patient. Now, the second important point is the large non-restrictive VSD. This would allow the movement of blood, the non-restrictive movement of the blood from the right ventricular towards the left side. Now, the most confusing point among these four is this aorta overriding the VSD. What does this mean, aorta overriding the VSD? Let's understand this with a diagram. This is your right ventricle, this is the septum, and this is your left ventricle, right? Uh, Now, normally what happens is aorta lies over the left ventricle only, like this. In this tetralogy of Fallot, what happens is there is dextro movement, the right side movement of the aorta, such that it overlies the septum, the ventricular septal defect. But this overriding is always less than 50%, right? That is also an important point. So now the aorta will lie over this septum, right? And this is always less than 50%. Why? If it is more than 50%, then it is known as another defect known as DORV, double outlet right ventricle, right? So why is this defect important? So due to this overriding of aorta over the VSD, the blood flows directly from the VSD towards the aorta instead of going into the left ventricle. That's why there is no left ventricular hypertrophy seen in the tetralogy of Fallot, because the blood is directly going from the right ventricle through the VSD towards the aorta, because aorta is overriding the VSD, but it is always less than 50%. And fourth important point is the concentric hypertrophy of the right ventricle. Now look at this diagram. So what happens? The blood flows from the SVC and IVC into the right atrium. From the right atrium, it goes in the right ventricle. But instead of going towards the pulmonary circulation via pulmonary artery, now there is an obstruction in the pulmonary artery. There is right ventricular outflow tract obstruction. Due to this obstruction, the blood now prefers to go towards the site of least resistance, which is through the VSD. It goes directly into the aorta, which is overriding that VSD, right? And due to this pressure overload, which in the right ventricle also undergoes the hypertrophy, right? So this is the important component of tetrad of TOF. Now let's understand the pathophysiology of tetralogy of Fallot. So there is first is there is right ventricular outflow tract obstruction. Second, there is large non-restrictive VSD. So the blood after entering into the right ventricle have two options: either it goes into the pulmonary artery, or through the VSD it goes into the aorta. But as the lumen of the pulmonary artery is narrowed due to the right ventricular outflow tract obstruction, the blood prefers to goes towards the aorta, right? So there is right to left shunting of the blood that is happening. Now this right to left shunting of the blood leads to the cyanosis in the child. So that is the main component. Due to the right ventricular outflow tract obstruction, plus the presence of the large VSD and also the aorta overriding the VSD, but the overriding is always less than 50%. It leads to the blood going from the right side towards the left side, which leads to the cyanosis in the child. Now the important points: the severity of this cyanosis, the severity of this pulmonary stenosis is directly proportional to the severity of cyanosis. More the pulmonary stenosis, more the obstruction is, more the blood will be shunting towards the right side and more will be the cyanosis in the child. And also the more severe this pulmonary stenosis is, the earlier the child will present with the symptoms. For example, if there is very severe pulmonary stenosis, then there will be very little blood going towards the pulmonary circulation and there will be very little oxygenation happening. The neonate can be cyanosed from the birth itself and can be dependent on the ductus arteriosus for the little oxygenation that is happening. And as soon as the ductus arteriosus gets closed, then there will be no oxygenation happening and the child can present with the severe cyanosis at that time. So the severity of the pulmonary stenosis also decides the timing of the presentation of the child. More severe the pulmonary stenosis, earlier the child will present. This diagram also shows that the more severe the obstruction is, the less the blood will be going into the pulmonary circulation, and the earlier will be the presentation, and more will be the cyanosis because of the right to left shunting. Now let's discuss the murmurs in TOF. Now there is a concept for the murmurs. For the murmurs to be present, there has to be turbulence present. Now we discussed that the VST which is present in the TOF, it is large and it is non-restrictive. It is not causing any restriction of movement of blood. So it won't lead to any kind of murmur. So that is a very important point. The VSD in the TOF is silent and there is no shunt murmur present in the TOF. The shunt is the central defect which is usually not present. So because of the large VSD present, there is no turbulence which is happening. There is no obstruction, no restriction of blood moving from the right side to the left side through that VSD. So that is why there is no shunt murmur present. Now, but there is a murmur which you hear in a TOF patient, that is not the shunt murmur, but that is the flow murmur. Now understand, when the right ventricle will contract, there is a narrowed orifice. So the blood will has to go through that orifice towards the pulmonary trunk, right? That will lead to the turbulence of the blood flow and that will produce a murmur, which is known as the ejection systolic murmur. This is a kind of a flow murmur. Now see this, to understand this concept. This is a water pipe and you have pressed that pipe from the middle, and that leads to more narrowed orifice. So as the orifice gets narrower, that will lead to more turbulence and more will be the intensity of the murmur, right? So as the pulmonary stenosis will become from mild to moderate type, the stenosis increase, it will also lead to increase in the murmur. It will become loud and it will become harsher. But imagine this, now you have pressed the pipe so tight that there is no or little blood flow happening. So as the blood flow is itself decreased, now there won't be any murmur, because for the murmur to happen, there has to be some blood flow, right? That happens when there is severe pulmonary stenosis and during the hypercyanotic or TET spells. There is little or no blood flow happening. That leads to the absence of murmur or reduced murmur intensity and the duration as well. So this is a very important concept. The severity of pulmonary stenosis is inversely proportional to the intensity and the duration of the ejection systolic murmur. More severe the pulmonary stenosis is, less the blood will be going through the pulmonary artery, and as the less blood will be going through that, there will be reduced intensity of murmur and there will be reduced duration of murmur. Now why there is no CHF in TOF patients? Yes, because the right ventricle can get completely decompressed via the VST into the aorta, right? So the right ventricle can get completely decompressed. So there is no overload of the right side. So that is why there is no CHF in TOF. Now there are certain conditions which can lead to the CHF in TOF patients, and these conditions you have to remember. These are very important conditions. It includes the anemia, infective endocarditis, severe hypertension, right ventricular dysfunction or failure, and regurgitant lesions, aortic regurgitation, and TR. How to remember this? For this, I have a mnemonic here. Now H stands for the hypertension, E for endocarditis, which is infective endocarditis, A for anemia, and for R you have two things. First is the right ventricular failure or dysfunction, and the regurgitant lesions, aortic regurgitation and tricuspid regurgitation. What are the clinical features which you can see? Of course, you can see the cyanosis in the patient. There can be exercise intolerance. There can be dyspnea on exertion. To prevent that, the child will assume the squatting posture, and there can be TED spell or hypercyanotic spells. Now, examination findings. These two pictures demonstrate the important examination finding. First is the cyanosis, central cyanosis you can see, and second one is the clubbing. Now, let's discuss the heart sounds. S1 is completely normal. In S2 in children with TOF is mostly single, and it only has one component, that is A2. The P2 component is soft, mostly inaudible, and it is delayed. Now, chest X-ray findings, which are very important. You can get the visual of this as well. Now, the size of the heart is normal in the TOF patient. The now right ventricular hypertrophy. Now, RVH leads to the lifting, is responsible for lifting the apex, cardiac apex, which you can see. This is the lifting of the cardiac apex. Can you see this? This rounded structure, it is getting lifted up. This is due to right ventricular hypertrophy. Now, what about the cardiac seal out? There's a French term. We call it as cour en sabot, which means boot-shaped heart. Now, see this. Can you see the boot right now? This is the boot-shaped heart, which you can see in TOF patient, which is due to right ventricular hypertrophy. Now, what happens to this left-sided heart border? Can you see this concavity on the left-sided heart border? This concavity, this is the pulmonary artery bay area. Due to less blood going towards the pulmonary artery becomes small and stenosed and dysplastic. So that is why this concavity is present on the left heart border due to the small or absent pulmonary artery, which leads to concavity. And also less blood going towards the pulmonary circulation leads to the pulmonary oligemia. Now, to revise the important components of the chest X-ray in TOF patient, first, the cardiac size is normal. Second, there is right ventricular hypertrophy, which leads to the upturning of the cardiac apex. Third, the cardiac seal out is in the shape of a boot, so cour en sabot. The left heart border has a concavity on the pulmonary artery area due to the small and stenosed or dysplastic pulmonary arteries. And fifth is the pulmonary oligemia. Now, there is one important finding which usually is present only in 20% of the cases, which is right-sided aortic arch. This is present in TOF patient only in 20% cases. So how can you identify this? This is present in this image. See carefully. Can you see this? The outline of this trachea. There is an indentation which is present. This is due to the presence of the arch towards the right side. Usually it is present on the left side, but in TOF patient, in 20% of the cases, there can be right-sided aortic arch, which can be identified by indentation you can see on the trachea, right? So now the ECG findings which you can see. ECG findings, it involves the right axis deviation. Second, there can be right atrial enlargement, which can lead to P pulmonale due to right atrial enlargement. And the signs of right ventricular hypertrophy you can see that will involve the dominant R wave in the right precordial leads V1 and V2. There is RSR dash pattern, which is a rabbit ear pattern, which you can see in the right sided precordial leads as well. It all signify the right ventricular hypertrophy, and usually the T waves are inverted in V3R and V1, but they will be positive in cases of RVH. Right? What is the investigation of choice? 2D echo, two-dimensional echo. With echo you can identify the degree of RVOT obstruction, and you can also identify the degree the degree of aorta overriding the VSD. So most of the cases you don't need to do anything else. Echo will will make the diagnosis. Now, there are certain conditions where you have to do the cardiac catheterization and CT angiography. What are those conditions where we have to do that? First is the presence of aortopulmonary collaterals. What happens is when there is a long-standard TOF patient, there are collaterals which get formed between the systemic and the pulmonary circulation as the body is getting very little oxygenated blood. These collaterals are known as aortopulmonary collaterals. And to identify those, we have to do the cardiac catheterization. Sometimes with echo, you are not able to identify these. So, presence of aortopulmonary collaterals, also known as MAPCAs. You have to do cardiac cath. Now, CT angiography. In few patients, like 5 to 10% of the cases, there is an aberrant coronary artery overlying the right ventricular outflow tract. So you have to identify those arteries and to protect them during the surgery. Now, what are the complications of TOF? So, important complications are cerebral thrombosis. This is common in children less than 2 years of age. Why does it happen? It happens because of the extreme polycythemia and dehydration present in TOF patients. It involves the cerebral veins and the dual sinuses, and it can lead to stroke and hemiplegia in the patient. Now, brain abscess is common in children more than 2 years of age. The child will present with the signs of raised ICT, headache, vomiting. They can even have seizures. They can have focal neurological deficit, and fever can also be present. To treat this, we will treat with antibiotics as well as surgical drainage. Other common complication can be infective endocarditis and anemia, usually iron deficiency anemia. This anemia is very common in children with TOF. That's why all children with TOF we give iron supplementation. It prevents the cyanotic spell as well. Now, what is the treatment? Mainstay of the treatment is surgery. Now we can perform this surgery as early as the first month of life. Earlier we used to do palliative surgery first and later on do the definitive surgery, but now the guidelines have changed. We prefer doing the corrective surgery in the first time only, because it has a theoretical advantage. If you do the surgery early, it allows the pulmonary artery to grow normally, right, and prevent the small or dysplastic pulmonary artery. Now you can do it as early as first month of life. Ideally you should do it before the occurrence of cyanotic spell. Now this corrective open heart surgery which we do, so we have to correct all the components of tetralogy of Fallot. The most important one is the RBOT correction, right? In the RBOT correction, we have the infundibular stenosis most common, so we remove the hypertrophied muscle in the infundibulum. In case the pulmonary stenosis is present, we can do the valvotomy. We can open the valves without removing the tissue. But if the pulmonary annulus is also involved, then we have to do valvectomy, remove the valve, part of the valve, and then do the transannular repair. Now, the problem with this is when you do the valvectomy and transannular patch repair, it will lead to the complication of mostly this pulmonary regurgitation. So that is why we don't want to do that, right? And as early as you do the surgery, there will be less chances of doing this. There will be less chances of doing this transannular patch repair. That is why we prefer to do the surgery early. Second is this VSD patch repair. This is what we do in the corrective open heart surgery. Now, what about the palliative surgery? This palliative surgery leads to the connection between the systemic and the pulmonary circulation, right? And this is a very important. Now, the palliative surgery leads to the connection between the systemic circulation and the pulmonary artery, so that the more blood can go towards the pulmonary artery for oxygenation, towards the lung for oxygenation. And this palliative surgery is Blalock-Taussig shunt. Now, this is a very important surgery because it leads to the birth of modern pediatric heart surgeries. What happened in this Blalock-Taussig shunt? See this. This is the first operation that they performed. This is the classic Blalock-Taussig shunt. There is a direct connection which is present. They made the direct connection between the subclavian artery and the pulmonary artery, right? This was the classic. Now, what we perform nowadays is the modified version of this. Now they use a conduit or graft. This is a conduit, right? A conduit or graft is present between the subclavian artery and the right pulmonary artery that allows the mixing of the blood and the better oxygenation to be present, right? We do side to side anastomosis between subclavian artery and pulmonary artery. Now you can see there is third name written in this image. This is Blalock, this is Taussig, and this is Thomas. So Blalock was the so the Taussig was the person, was a pediatric cardiologist, French pediatric cardiologist. He gave the concept for the surgery that if you improve the pulmonary circulation, that can help the children. Right now, the Blalock was the surgeon who performed this surgery, and the Thomas was the person who perfected this surgery. He was kind of a like unsung hero. No one knows about him, but he was not a doctor, but his contribution for this surgery was immense. He was the one who perfected that surgery. He was standing behind the Blalock guide in the OT in the operation theater, guiding him how to do this surgery with more perfection, right? So that is it about this. In the next video, we are going to discuss another important topic linked to this, that is hypercyanotic spell, right? Thank you.